This conference will now be recorded.
Good morning, everyone. Am I audible?
Yes, ma'am.
Yeah. Today, our topic is on tuberculous meningitis. I hope it is already covered. You people are very well versed with bacterial meningitis. So today, topic is on tubercular meningitis. It is nothing but tuberculosis of the central nervous system, and it is the most serious complication in children and is fatal without any appropriate or prompt treatment to this condition. So why this tubercular meningitis occurs? So it usually arises from the formation of metastatic caseous lesions in the cerebral cortex or the meninges due to any hematogenous dissemination of the primary infection. So from the primary infection through this lymphohematogenous spread, finally there will be formation of all these metastatic abscesses, caseous lesions in the cerebral cortex or meninges, leading to tubercular meningitis. So this is the thing, basic like introduction. So the same thing, tuberculosis of central nervous system is most serious complication in children and it is fatal without prompt and appropriate treatment. So what are the forms of CNS tuberculosis? That includes, it could be like tubercular meningitis, tuberculoma, or spinal arachnoiditis. Out of this, tuberculous meningitis is the most common form of CNS tuberculosis. So that's why we are dealing with this entity today. And tubercular meningitis is most devastating and disabling, from with around 1 lakh new cases appearing every year around the world. So the incidence and prevalence of tubercular meningitis varies around the world depending upon location, age group, and prevalence of HIV. So this disease is more common in immunocompromised conditions. So even the prevalence of HIV also determines the incidence as well as prevalence. You all know what do you mean by incidence. Incidence is occurrence of new cases and prevalence means incidence of means like it includes both old as well as new cases. Because it is a chronic entity, prevalence of these diseases will be like more. Coming to Indian national guidelines for extrapulmonary tuberculosis estimates that TB meningitis constitutes 1% of all the TB cases. TB meningitis is a medical emergency and outcome depends on early diagnosis and appropriate treatment. If we intervene early, the outcome will be good. If we intervene late, it will enter into final stages where decerebrate or decorticate posturings or involvement of cranial nerves. All these things will happen. At that point of time, outcome is very poor. So one have to be cautious in putting your mind the differential diagnosis of tuberculous meningitis for every case of meningitis. So we will not miss it in initial stages so that outcomes will be good. TB meningitis complicates approximately 0.3% of untreated tuberculosis infections in children. TB meningitis, the most common age group, is in between 6 months to 4 years of age. So this is the brief introduction of tuberculosis involving the central nervous system, where TB meningitis is the most common form, and the incidence and prevalence depending upon the age as well as your prevalence of HIV in that particular thing. So coming to your pathophysiology, what happens? Usually infection occurs after inhalation of bacilli in infected respiratory secretions, right? The same thing, the primary complex formation or all the things that will be same for initial stages. So what happens in lungs? The inhaled respiratory secretions containing Mycobacterium tuberculosis will multiply in the alveolar macrophages. Within 2 to 4 weeks, through blood circulation, bacillus spread to extrapulmonary sites and produces small granulomas in the meninges and adjacent brain parenchyma. So these small granulomas, we call it as rich focus. So like Gons complex in lung, the same thing, the granulomas in the brain, we call it as rich. So rich focus. When mycobacterium contaminated within these lesions are released into the subarachnoid space, they causes meningitis. What happens? Why? What is the leading factor leading to rupture of that particular granulomatic focus called as rich focus is the decreased immunity is believed to play a role in the rupture of this particular foci. So this is all the thing like primary infection followed by lymphohematogenous dissemination leading to metastatic caseous lesions in the cerebral cortex or meninges, discharging few tubercular bacilli into the subarachnoid space, forming gelatinous exudate, leading to infiltrates in the corticomeningeal blood vessels. After infiltration, they form inflammation, obstruction, and infarction of cerebral cortex. So, inflammation, obstruction, infarction of cerebral cortex. The commonest site involved in this process is brainstem. So, brainstem we have contained all the cranial nerves arising from that. So, most of the cranial nerves involving are cranial nerve 3, 6, and 7, leading to cranial nerve palsies. Even these exudates sometimes will interfere with the flow of cerebrospinal fluid in and out of the ventricular system, usually at the level of basal cisterns. What happens? All this obstruction leading to communicating hydrocephalus. So the combination of vasculitis, infarction, cerebral edema, and hydrocephalus resulting in severe damage that can occur either gradually or rapidly. And also not only the cranial nerve palsies, hydrocephalus, and what we call like vasculitis or infarcts or cerebral edema, all these are the manifestations of this particular entity of tubercular meningitis. Even we see like electrolyte abnormalities in the form of salt wasting or syndrome of inappropriate antidiuretic hormone, where inappropriate secretion of antidiuretic hormone leading to cerebral edema, where sodium and water retention occurs. All these can also contribute to the pathogenesis of tubercular meningitis. So we have to remember out of this complete slide, this is due to not due to primary infection in the brain. It is due to lymphohematogenous dissemination, resulting in all these things. Finally, the most common site that is involved in tubercular meningitis, the most common thing involved is brainstem. And also, the first thing is brainstem involvement, followed by all these inflammation obstruction can also leads to obstruction of outflow of CSF, leading to your hydrocephalus event. So this is brief on pathogenesis of tubercular meningitis. I hope you have to learn this particular simple table so you can reproduce it in your examination. Coming to the clinical features entity, we already discussed the most common age group is in between 6 months and 4 years of age. See, occasionally like tuberculous meningitis occurs many years after the infection. We already know when will that rich foci means ruptures. One of the pathogenesis or one of the thing is when the immunity is suppressed, it plays a role in the rupture of that particular focus. So that is the thing. So it can take sometimes many years after the infections. At that time, the presentation will be a bit late, but it is most common in the age group between 6 months and 4 years. When rupture of one or more of the ependymal tubercles discharges tubercle bacilli into subarachnoid space, that all we already discussed. So one you have to remember, the clinical progression can be either gradual or rapid. Rapid progression tends to occur more often in infants and young children. So infants and young children, they will not give appropriate time. So we have to intervene very early to prevent all the complications and to expect some better outcomes if we intervene early. So when the onset is gradual, So at that point of time, we can divide tuberculous meningitis into 3 stages. First stage, it typically lasts for 1 to 2 weeks. In this particular stage of meningitis, it is characterized by non-specific symptoms such as fever, headache, irritability, drowsiness, and malaise. Usually there are no focal neurological signs in this particular stage, but in infants, they can experience like stagnation or loss of developmental milestones. So we can attribute something to tubercular meningitis when with all these signs, sometimes the infant will be like developmentally in delay stage. Already attained milestones may be lost because of this particular entity. So usually first stage is a non-specific stage because there are no specific symptoms that are the true indicators or pointers that this could be tubercular meningitis. So even with these symptoms, one have to suspect maybe this could be in the first stage of tuberculous meningitis. And like even the positive history, if the family is having any contact of tuberculosis and all these things will lead to still more specific favorable things to get into a conclusion it could be tubercular meningitis. Coming to your second stage, what happens in the second stage? Usually begins more abruptly. After the first stage, the second stage, like the course will be somewhat rapid. In this particular second stage, the common features that we do come across are lethargy, nuchal rigidity, that is neck rigidity, hypertonia, the tone of all the limbs will be increased because of the upper motor neuron lesions. So this nuchal rigidity, hypertonia, because cerebral cortex is involved, we expect seizures because of parenchymal involvement or cerebral cortex involvement. Because of raised intracranial pressure and because of meningitis, there may be signs that is called your Kerning sign and Brudinsky signs will be positive. Because of your raised intracranial pressure, the child may be having vomitings, headache, and all other things. We already discussed the most common path involved in this pathogenesis of tuberculous meningitis is your brainstem. So brainstem is involved, resulting in cranial nerve palsies, and the most cranial nerve that is commonly involved are third cranial nerve, sixth cranial nerve, and seventh cranial nerve. And we do expect some focal neurological deficits even. So this is somewhat specific signs we can appreciate in your second stage. And one more thing you can see, like some children have no evidence of meningeal irritation but can have signs of encephalitis such as like disorientation, movement disorders, or speech impairment. So we can expect even movement disorders or speech impairment or disorientation even in the second stage. So the accelerating clinical illness usually correlates with development of hydrocephalus, increased intracranial pressure, and vasculitis. This is all the thing we discussed earlier in your pathogenesis. Some children have no evidence of meningeal irritation. We already told you these points also. So these are the common clinical features resulting due to meningeal irritation. So do not ignore if the child is not having any signs of meningeal irritation, because sometimes there will be no meningeal irritation. Only the child will be having only signs of encephalitis, that is like disorientation, movement disorders, and speech impairment. So your second stage, along with your meningeal signs, you can expect even without any meningeal signs, only with your encephalitis presentation. So you should know all these entities, so one should not miss the case of tuberculous meningitis. This is the Kerning sign and this is Brudinsky sign. Resistance to extension of leg when the hip is flexed, that is called as Kerning's. Flexion of the hips and knees in response to neck flexion. This is called as Brudinsky's neck sign. This is a picture showing sunset sign and also hydrocephalus. So the next entity, what happens in third stage? This is most fatal stage. It results in coma, hemi or paraplegia, hypertension because of raised intracranial pressure, decerebrate posturing, deterioration of vital signs, and finally leads to death. So eventually, the third stage is most fatal stage. So one have to recognize why we are categorizing into these three stages. If at all the child presents to you in the first stage and you have a vigilant look at that point of time, we can treat it early and the outcomes will be good. There is no point if we diagnose at the point of third stage, outcomes are very poor. So these are the varied clinical presentations that can come across in the case of tuberculous meningitis. It is divided, it can be either rapid or gradual. Rapid more often in infants and young children. And one more clinical pointer is in infants, even you can see like regression of milestones or stagnation in developmental process. That is one of the pointer. Followed by your stages. Stage 1 usually non-specific, stage 2 in particularly the clinical features of meningitis you explain, as well as without any significant clinical features of meningitis, only encephalitis picture like movement disorders and all the things you can see. Third stage is a fatal stage. So these are in brief on clinical features. It consists of like 3 stages you have to remember. So in this we dealt with some brief introduction on TB meningitis along with your pathogenesis and clinical features. This is signs of decerebrate posturing. Head and neck are arched, legs are straight, toes are pointed downwards, even arms are straight, extended and hands are curled. This is the picture of decerebrate. So the prognosis of TB meningitis correlates most closely with the clinical stage of illness at the time of treatment is initiated. We already discussed the same point. Majority of patients in the first stage have excellent outcome, whereas most patients in third stage who survive have permanent disabilities like blindness, deafness, paraplegia, diabetes insipidus, and mental retardation. So act early to prevent all these complications. Prognosis for young infants is generally worse than for older children. So this is one of the meningitis scale, that is modified MRC scale, where in stage 1 alert and oriented without any focal neurological deficit. Stage 2 the GCS score is around from 10 to 14 with or without focal neurological deficit, or score of 15 with focal neurological deficit. Stage 3 the score is less than 10 with or without focal neurological deficit. You need not memorize all these things. Just you have to know the basics, what is pathogenesis and what are the clinical features. There are 3 stages in which stage 1 is non-specific, stage 2 is meningitis like picture, stage 3 is very fatal resulting in coma and decerebrate posturing. So this is brief introduction, pathogenesis and clinical features. Next is your so next, am I clear? Shall I continue with the treatment part? Shall I continue with the treatment part? Any doubts are there in pathogenesis or clinical features? Please someone answer.
Continue, ma'am.
Yeah, okay. So coming to your treatment part. So how do you manage this case of tuberculous meningitis? There are core 3 strategies. One is killing the TB bacilli with anti-tubercular treatment. Another one more thing is manage the host immune response, followed by your supportive care and managing the complications. The greatest predictor of survival from TB meningitis is the initiation of ATT before the onset of coma. That is all we discussed. That's why we dealt briefly with the clinical stages. So when to intervene, at what point of time we intervene, the outcome will be good. So the treatment strategy is based on the pulmonary tuberculosis management regimens. So phases of treatment: intensive phase and continuation phase. Intensive phase, we eliminate the bacterial load, prevent emergence of drug-resistant strains. At least we need to use 3 bactericidal drugs. In continuation phase, you have to continue and complete the therapy. Eliminates most of the residual bacilli. At least at this point of time, we need 2 bactericidal drugs. So intensive phase 3 drugs, continuation phase 2 drugs. So these are the tubercular drugs. First line drugs, there is nothing new in it. You have to know this entity where drugs used in MDR, TBR, clofazimine, aramino-salicylic acid, bedaquiline, and delaminid. These are the new drugs introduced in multi-drug resistant tuberculosis cases. So first line drugs: rifampicin, isoniazid, pyrazinamide, ethambutol, and streptomycin. There is nothing new in it. The same thing, but the doses you have to know. According to RNTCP, rifampicin 10 to 20 mg, average of 15 mg, maximum dose one can give is 600 mg per day. The CSF penetration of this drug is only 10 to 20%. Adverse effects: flu-like symptoms, nausea, vomiting, orange-colored urine, and hepatotoxicity. Isoniazid, the CSF penetration is 80 to 90%. So this is more useful when used in your intensive phase because CSF penetration is good. The maximum dose is 300 mg per day. Adverse effects: hepatotoxicity, peripheral neuropathy, lupus-like syndrome, confusion, and seizures. You have to memorize all these adverse effects. There is nothing to explain in all these things, but you have to know what is the best drug that is having CNSF penetration is isoniazid. Pyrazinamide, the dose is 30 to 40 mg per kg per day, and the maximum dose should never exceed 2 grams per day. CSF penetration is 15 to 25%. Ethambutol, average 20 milligrams, maximum dose is 1.5 gram per day. CSF penetration 20 to 30%. The most common complication is dose-related retrobulbar neuritis. Streptomycin, maximum dose is 1 gram per day. The dose average is 20 milligram per kg per day. CSF penetration is 10 to 20%. The most common complication is vestibular toxicity and nephrotoxicity. Coming to your second line drugs, levofloxacin, moxifloxacin. Out of this, fluoroquinolones, levo and moxifloxacin is having penetration of CSF 70 to 80%. Ethionamide is having the best penetration of CSF, that is 80 to 90%. And also cycloserine, the CSF penetration is even good, that is also 80 to 90%. Other drugs, bedaquiline dose not yet determined. So we have to supplement pyridoxine. Isoniazid interferes competitively with pyridoxine metabolism by inhibiting the formation of active form of vitamin and hence often results in peripheral neuropathy. Supplementation with 10 milligram per day is recommended to all those receiving isoniazid therapy. So these are all the same drugs that we use in every case of tuberculosis, nothing new it. But you have to know in what are the drugs that is having maximum CSF penetration to select the drugs that will be easy. That's all. Remaining, there is nothing in it for you people to tell. So the recommended guidelines, the WHO guidelines recommend 2 months of HRZS followed by 10-month continuation with H&R. But the current RNTCP guidelines, that is National Tuberculosis Elimination Program guidelines, this is the newer guidelines, recommends 2 months of 4 drugs, isoniazid, rifampicin, pyrazinamide, and ethambutol, and 9 to 12-month course of the continuation phase with 3 bactericidal drugs, that is isoniazid, rifampicin, and ethambutol. This is the recent recommendation by RNTCP. So the total duration will be around 14 months. So the total duration is 11 to 14 months, minimum of 11 months to maximum of 14 months, with 4 drugs in the initial phase and 3 drugs with the continuation phase. That is the new current guidelines by RNTCP. The Index TB guidelines recommend 2 months of HRZE and 7 months of HRE. So you need not remember every guideline, just you go with your RNTCP guidelines, that is newer guidelines, 2 months with 4 drugs and followed by 9 to 12 months with 3 drugs. So the major concerns are, we already discussed, poor CSF penetration of rifampicin and ethambutol. Use of high doses of rifampicin is not yet clear. The choice of 4th drug remains ambiguous. Commonly used drugs are ethambutol and streptomycin. Both have low CSF penetration and exhibit adverse effects in form of optic neuropathy and vestibular toxicity, respectively. The rationale in drug-sensitive paucibacillary tuberculosis is to prevent isoniazid resistance, and it does not increase bacterial killing or improve outcome. But in TB meningitis, the rationale of fourth drug is also to increase bacterial killing and patient survival, since the CNS penetration of rifampicin is very low. This is not required for you people. So coming to the entity where it is like drug-resistant tubercular meningitis. What do you mean by multi-drug resistant tuberculosis? At least resistant to both the drugs, isoniazid and rifampicin. In extensively drug-resistant tuberculosis, it is resistant to isoniazid and rifampicin, as well as any fluoroquinolones and any of the 3 second-line injectable ATT drugs, amikacin, kanamycin, or capreomycin. This is on extensively drug-resistant tuberculosis. Multi-drug resistant, 2 drugs, isoniazid and rifampicin. Extensively drug-resistant tuberculosis, resistant to isoniazid and rifampicin, as well as any fluoroquinolones and any of these 3 second-line injectable drugs. And how this drug resistance could be? It could be primary or it could be acquired. How we get primary drug resistance? Due to transmission of drug resistant strain in someone who is not taking ATT. So already the person is getting infection with the drug resistant bacilli itself. We can't do anything. Acquired where resistance developing in someone who has already taken ATT. So the WHO guidelines for treatment of multi-drug resistant tuberculous meningitis recommend that initially at least 5 effective drugs should be used, comprising a fluoroquinolone and an injectable second-line agent, and duration of treatment should be 18 to 24 months. So WHO guidelines for MDR tuberculosis, at least of 18 to 24 months, like 1.5 to 2 years we need to take. For not a drug resistant tuberculosis, the maximum of 12 months. So corticosteroid therapy. When do we use corticosteroids? It is used in the treatment of TB meningitis along with your anti-tubercular treatment. They help in reducing the inflammation of surface of the brain and of the blood vessels. And also one of the most common complication of TB meningitis is your raised intracranial pressure. So pressure inside the brain, thus reducing the mortality from tubercular meningitis. What is the dose we recommend in TB meningitis? The steroid dosage is 1 to 2 mg per kg per day of prednisolone over 1 month. Then after using steroids for more than 14 days, we can never stop it abruptly. So we have to taper in the next subsequent month. So total duration will be like 8 weeks. So studies showed that prednisolone dose of 4 mg per kg per day for 1 week followed by 2 mg per kg per day is associated with lesser tuberculomas as well as infarcts. But at 4 mg per kg per day for 1 month, there was an increase in the incidence of optic atrophy, infarcts and hydrocephalus compared with those taking a lower dose for the same duration. So the better to give the dose of 1 to 2 mg per kg per day, because with 4 mg per kg per day, they'll be having some complications lessen and some complications that are worsening. So we cannot take a chance. So better to use optimally the steroids for at least of 8 weeks with 2 mg, 1 to 2 mg per kg per day in the first 1 month, followed by tapering by another 1 more month. If we take 2 mg per kg per day, like as a WHO guidelines, mental retardation and spasticity, they were noted were less in those receiving at that particular duration and dose. First of all, if for suppose if the child is in encephalitis stage or something, at that point the child can unable to take it orally. At that point of time, we use intravenous dexamethasone at a dose of 0.4 mg per kg in 24 hours in 3 to 4 divided doses. May be preferred with a slow switch to oral therapy and then followed by tapering dose. According to RNTCP, these are recent guidelines, recommends dexamethasone 0.6 mg per kg per day or its equivalent is used for 4 weeks and then tapered over next 4 weeks. So we can use either prednisolone or dexamethasone. Prednisolone at the dose of 1 to 2 mg per kg per day for 4 weeks followed by tapering and for another 4 weeks. The same thing, dexamethasone, the dose is 0.6 mg per kg per day or its equivalent for 4 weeks followed by tapering in the next 4 weeks. This is the recent IAP RNTCP guidelines of by 2019. So till now we discussed, I already told you there are 3 strategies. First, to kill the tuberculosis present. Next, to treat complications or corticosteroid therapy. The last is your management supportive care. So what are coming to the treatment of complications? The complications we expect in tubercular meningitis are raised ICP, hydrocephalus, vasculitis, acute seizures, and hyponatremia. In pathogenesis, we discussed every entity why all these complications can occur. So how will you treat your raised intracranial pressure? So cerebral edema due to encephalitic process, infarcts with edema, hydrocephalus, tuberculomas, and electrolyte disturbances. Any one can aggravate this typical feature of raised intracranial pressure. So how will you reduce? We use the osmotic agents like mannitol or hypertonic saline to reduce the ICP, particularly in those who does not require any surgical intervention. Hydrocephalus. It is found in more than 80% of children with TB meningitis. Communicating hydrocephalus can be managed with medical management. What do you mean by communicating? There is no obstruction at any point of time. All these particular like foramen of Monro, third ventricle, fourth ventricle, lateral ventricles, the pathway is fine. So there is no obstruction. So we can treat it with the medical management. We can treat either with acetazolamide and furosemide. Acetazolamide is a carbonic anhydrase inhibitor where it reduces the production of cerebrospinal fluid. If at all non-communicating or obstructive hydrocephalus, there is no other point. So we need to relieve that obstruction. In non-communicating as well as in failed medical treatment, that is indicated to put a shunt, that is ventriculoperitoneal shunting. Endoscopic third ventriculostomy is an alternative surgical option to divert the CSF flow. Success rate is around 60%. Vasculitis, stroke due to tuberculous vasculitis are usually multiple and bilateral, involving deep gray matter like caudate or thalamus as also anterior and genu of internal capsule. So these are the things where it is most commonly involved. Vasculitis, it is also an inflammation. Corticosteroids may be beneficial because of their anti-inflammatory effect. Aspirin, that is it prevents platelet aggregation and all the things, so it might prevent stroke in tubercular meningitis, but still the studies are ongoing. How do we treat with acute seizures? Seizures can occur in 50% of children. Phenytoin is the most commonly used anti-epileptic drug for acute management of seizures. Many anti-epileptic drugs interact with anti-tuberculosis drugs and affect the metabolism of each other and are also hepatotoxic. So treating seizures in a tuberculous meningitis entity is a bit difficult because of the drug interactions and also the potential complication like hepatotoxicity. Therefore, careful monitoring during drug therapy is necessary when treating the case of tuberculous meningitis with your acute seizures. So till now we discussed how to manage the complications like raised ICP. We can either treat with the mannitol or 3% NaCl, and also we use acetazolamide and furosemides in non-obstructive hydrocephalus. If hydrocephalus is obstructive, then we go with your ventriculoperitoneal shunting and ventriculostomy. These are, or even we can use it in a failed medical treatment. Followed by your acute seizures. How do you treat your acute seizures? Your acute seizures can be treated with a particular or appropriate anti-epileptic drug, but because of serious drug interactions and all those things, monitoring is often recommended. Next is your hyponatremia. Lower serum sodium levels are found in 35 to 65% of tubercular meningitis. What happens if serum sodium is low? If serum sodium is low, usually water moves from high osmolarity to low osmolarity, right? If for suppose in your serum sodium is low, so your water content, for suppose your cells will be having high sodium, water will be moving here to there. So automatically there will be finally cerebral pontine myelinolysis, and all these things are the expected complications. So why the serum sodium levels are getting deranged in case of a tuberculous meningitis? It may be due to cerebral salt wasting syndrome, where loss of sodium is like dramatic. Both sodium will be lost in your urine and all the things. One more is syndrome of inappropriate antidiuretic hormone, where water retention is inappropriate out of your euvolemic condition. There is no point in conserving water. So that's why it is called as syndrome of inappropriate antidiuretic hormone, and also increased renal sensitivity to ADH. Hyponatremia is associated with increased mortality and morbidity in these children. Volume and sodium replacement is performed in a treatment with cerebral salt wasting syndrome, because in this both the water content as well as sodium content is gone. So we need to treat this complication along with your supportive fluids as well as your sodium. In this condition, even mineralocorticoid supplementation has also shown to be effective. For SIADH, it is inappropriate retention of your water and sodium. So fluid restriction is done. And if hyponatremia is severe, then go with your 3% normal saline. If at all required, any furosemide can be added during that process. So we expect this particular entity called as paradoxical worsening during treatment. What happens in this? So delayed inflammatory reaction which occurs weeks to months after starting ATT is called as paradoxical reaction. In HIV co-infected patients, after starting ART, we see this syndrome called as immune reconstitution inflammatory syndrome. It usually occurs because till then immunity is compromised, right? If we use some particular drugs, if the child is getting better, if immunity is getting better, so all these things can come across. So we see this paradoxical reaction and immune reconstitution inflammatory syndrome usually after 3 to 4 weeks after beginning of therapy, most frequently after treatment for 6 to 7 weeks, and last for about 2 months. Paradoxical reaction and iris may present with fever, worsening headache, seizures, and altered sensorium. So those reactions are usually treated with your steroids, which are anti-inflammatory drugs. One more entity in your tuberculosis is tuberculoma. This is not your topic. Here also the main treatment is ATT, but the duration of treatment is still uncertain. So another last, I think the class is very exhausting. I'll end up within 2 to 3 minutes. HIV associated tubercular meningitis. Here co-infection with HIV does not alter the clinical presentation of tubercular meningitis. We have to start 4-drug anti-tubercular treatment if it is diagnosed as drug sensitive. For the HIV infected children already on combination with antiretroviral therapy, their regimen should be reviewed to minimize any potential toxicities as well as drug-to-drug interactions with anti-tubercular drugs. For children who are not yet on this antiretroviral therapy, early combination of antiretroviral therapy initiation should be planned, preferably within 2 to 8 weeks of starting your anti-tubercular treatment. So if already the child is on treatment with HIV, then you can add your all 4 anti-tubercular drugs, and you have to monitor the potential drug interaction as well as potential side effects. If the child is diagnosed after this particular entity of tubercular meningitis, so you start with your tubercular drugs. Then within no time, like within 2 to 8 weeks, you need to start your antiretroviral therapy even. So what happens in these? Nucleoside reverse transcriptase inhibitors and efavirenz are least affected with anti-tubercular treatment. And ethionamide is preferred in TB meningitis cases because it penetrates cerebrospinal fluid better and can be used to substitute ethambutol or an injectable aminoglycoside. So it is preferred. Duration of anti-tubercular therapy remains the same. We already discussed. If at all it is drug sensitive, we give for 11 to 14 months. If it is drug resistant, we give for 18 to 24 months. Adjunctive therapy with corticosteroids in TB meningitis helps in reducing mortalities as well as long-term neurological impairment. We already discussed the steroids we use are prednisolone or dexamethasone. Prednisolone results in decreasing spasticity and optic atrophies. Some studies are there. So what is the outcome and prognosis? We already discussed outcome depending upon the stage at which you diagnose the case of TB meningitis. If you diagnosed at initial stages, the outcome will be good. So bad prognosis is usually associated with younger age of onset, malnourishment, hydrocephalus and focal neurological deficits, miliary disease, along with your HIV co-infection. The prognosis is very poor. These are all the stages we already discussed. So mortality and morbidity is low if treatment is initiated and early in stage 1, while in stage 3 almost 50% die. Survival shows some of the neurological deficits. Sequelae occur in 10 to 15%, which include intellectual disability, epilepsy, cranial palsies, blindness, deafness, and behavioral problems, and hydrocephalus. These are all the points we already discussed. That's why we had an extensive thing on clinical features, because clinical feature depends upon your prognosis, your management, and everything. Even hypothalamic disturbances may lead to precocious puberty, diabetic insipidus, obesity, and growth retardation. Intracranial calcifications are detectable after 2 to 3 years in 20 to 48% of patients with tuberculous meningitis. So how do you monitor and how do you follow up? Two components of follow-up, that is clinical follow-up and laboratory follow-up. Clinical, it should be done every month during your treatment. So ask your patient to come in every month till completion of your treatment. Once the treatment is completed, it may be every 6 months for at least of 2 years. An initial visit, it should be within 2 weeks of starting your therapy to recheck that patient is on correct dose and combination and is tolerating all drugs is desirable. So you started the patient on treatment. Your first visit is at 2 weeks of your starting of treatment. The subsequent visits are every month till your completion of treatment. Once the treatment is completed, you ask them to come every 6 months till 2 years of post treatment. On each follow-up, you have to assess all these following, like improvement in clinical symptoms, your physical examination, any potential drug side effects or toxicities for your medications, and also we need to treat the comorbid conditions simultaneously, like HIV. That's why we need to start even antiretroviral therapy within no time, like 2 to 8 weeks of starting your ATT. SAM, diabetes mellitus, should be monitored during each visit. For suppose if the child has an interrupted treatment, what happens? Interruption upon 4 weeks are managed by resuming the therapy. But if the drugs are interrupted over 4 weeks, the patient is investigated for acquisition of drug-resistant tuberculosis. Fine if the patient doesn't take tablets or for at least 4 weeks, you have to restart your therapy. If he took for more than 4 weeks and he stopped, you have to recheck whether any drug-resistant tuberculosis things are there or not. If on testing there is no rifampicin resistance is detected, then retreat with your first 4-line drugs and check for isoniazid resistance, then treat appropriately as either isoniazid mono or polyresistance cases. If rifampicin resistance is detected, then treat as multi-drug resistant tuberculosis. Lab monitoring, what are the parameters? Still now we follow up clinically, what are the things we see in your OPDs in clinical follow-up. In lab monitoring, lab investigations are, we have to check importantly what are the side effects that are for medications, like monitoring of drug levels for anti-epileptic drugs, liver function tests, only hepatotoxicity is considered or developed, CT or MRI at completion of treatment, or assessed to be unresponsive or deterioration while on treatment. So this is end of your class. I know it is a boring and exhaustive class. If any doubts are there, you can ask. All of you are there or left? Shall I end the class?
Yes, ma'am.
Thank you.